I'm with the University of Kansas Medical Center. For those of you who weren't in the last session, I'm the director of our Geriatric Education Center. We're one of 45 federally funded geriatric education centers in the country, and our mission is to disseminate information about evidence-based care and geriatrics, and we also work in the palliative care hospice area to healthcare professionals. So that is part of what we're doing here today. We work with a number of correctional facilities and have around the country on issues around care of older inmates and also on hospice palliative care, which we'll be talking about in the next session. We do not have any relevant financial relationships or commercial interests to disclose, and these are our objectives for this session. In the previous session, we talked some about a couple of models out there in care of older inmates. We're going to be talking now a little more about some of the curriculum pieces, as well as sort of what the programs look like in terms of the actual activities within the programs, and also give you all a chance to ask questions and also to tell us about what you're doing or what interesting things are going on around your areas in relation to this, because this is our chance to learn too. So what do you think is the most common cause of death in prison? Heart disease? Okay, anybody else? Yeah, basically, it pretty much follows, for the first two at least, the community pattern of heart disease, cancer, liver failure, complications from AIDS, respiratory's right up there too, COPDs and so forth. Probably within, I know my daughter's in medical school, and she was told her first year of medical school, she's now in her third year, that by the time she got out of medical school in the nation, cancer would actually exceed heart disease as a major cause of death. And I think we're creeping up on that pretty readily, because we're really able to manage heart disease much more effectively today than we have in the past, and we certainly see the rates of cancer increasing over time and even in younger people. So we're probably going to see some switchover even in the correctional institutions with seeing more deaths from cancer and comorbidities from cancer. So what are some of the common characteristics of our elderly versus our younger inmates, and why is this different? I mean, I think, correctional health providers and people with security and so forth that have worked in prisons have certainly been used to dealing with a younger population up until recent years. When we started doing this work with prisons about 7 years ago now, maybe close to 8, I was at an ACA meeting, and we were talking to a number of the people around the aging in the prisons and what an issue this was, and they sort of looked at us like we had 4 eyes and 10 arms or something, like, what are you talking about? And within about a 2-year span after that, it was like everybody is saying we're having these major issues in dealing with the aging of our population. It was like all of a sudden the light bulb came on. We've got a lot of people aging in our prisons, and there's some very unique characteristics of this population we're now having to deal with that we haven't really had to deal with in any numbers in the past. So we know certainly that our older inmates have a higher prevalence of chronic illness, and most have multiple comorbidities. They have heart disease, diabetes, COPD, liver failure, you name it. They've got lots of things going on all at the same time, and those are difficult things to handle under the best of circumstances. They also have a much greater likelihood of having cognitive impairment. We know that the chances of developing dementia go up with every decade of life after you're about 60. So, and then you actually have some who have some risk factors for other types of dementia, such as from alcohol, substance abuse, and so forth, that they might actually develop it at younger ages than that. So having to deal with the likelihood as this population ages of having dementia, the increase in dementia in your population, higher risk for accidental injuries, they fall more, They're more likely to hit their heads when they fall because of the ways they fall. And so you have much greater chance. They also, the bone fragility, they're much more likely to fracture their hip when they fall, their wrist when they fall, whatever. So you've got lots of issues to deal with along that. And as we talked about in the previous section, higher cost of care. Older inmates, older people in the community, you hear it all the time. You know, we have an aging society. What are we going to do? Medicare is going to break us, you know, on and on. So we're hearing this constantly, and it's no different in the prisons. People, as they get older, have more health problems, and health care is expensive. There's no doubt about it. If we look at it, chronic illness in the free world, if we look at older adults, and this is people 65 and over, about 80% of older adults in the free world have at least one chronic condition. And about 50% have 2 or more chronic conditions. So chronic conditions are not uncommon in the older population. A Harvard study in 2009 actually showed that 40% of the total prison and jail population had a chronic medical condition. So this wasn't limited to just older inmates. This is the total population in jails and prisons have some kind of chronic condition going on. And compared to Americans of the same age who live in the free world, they're 31% more likely to have asthma, 55% more likely to have diabetes, and 90% more likely to have a heart attack. So you're dealing with pretty significant discrepancies and disparities in health in these populations. So what are our options? We've talked about some of them in the previous session. Do we leave these people out in the general population? Well, we're finding that doesn't really work too well as people become frailer, more infirmed, have more health problems. They have trouble getting to the dining, they have trouble getting to Medline, they have trouble remembering where they're going. They are, you know, at really high risk in the general population. We've talked a lot, and there have been some very interesting studies just coming out on compassionate release and medical parole. A lot of press right now around medical release and compassionate release, medical parole, whatever you want to call it, of trying to get people as they age and become more infirmed out of the prisons, not keeping people in prison who really are no longer of danger to the community. Ones that, you know, have been put in for offenses that were not necessarily violent offenses but came in under mandatory sentencing and under 3-strikes outlaws and so forth. And we know that even for people who we know are dying, who we know could not hurt anybody in the condition they're in, it's very difficult to get them out. And if we even apply for compassionate release or medical parole, often by the time it even begins to get through the system, they've already died. So it's not something that we're finding very easy to do. Kathleen talked about at least a program where they're having more success of that by having guarantees of where they could place these people. The other issue is even if we do get it and do get them out, where do they go? Where do we house them? Where do we put them? What's going to happen to them out there in the community? And in the past, up until recently, we've used infirmaries a lot. So when people got too infirm, too debilitated to be able to be out in general population, they put them in the infirmaries. Well, now what we're hearing is the infirmary beds are filling up and they can't get the acutely ill into their infirmaries anymore, so therefore we've got to find other solutions to this. So one of the things that we had talked about in the previous session was, you know, one option is also developing special units within the prisons. This isn't a totally new idea. It's been done, I believe. Is anybody here from Virginia? I think Deerfield in Virginia has had an aging unit for some time. California has developed some special units within their facilities for both the aged and disabled. So there's been, you know, attempts at this at various levels across the board to do this, but I think we're seeing a growing interest in these kinds of options being available. So one thing that's talked about is being able to retrofit the prisoner prison and jail for the more vulnerable and the elderly. We could build new facilities outside the walls. Kathleen talked in the previous session about actually that they were actually able to identify a facility outside the walls of the prison that was set up as a nursing home to begin with, so that they were able to purchase that and use that particular facility. Jennifer talked about actually retrofitting units within the facility, the prison itself, to set aside separate units and to retrofit those to make them more friendly to the and the audio's good. Ooh, it went away. To make them more friendly for people who have infirmities and wheelchairs. So, for example, taking down the bunks, going to a single bed. Someone else was saying that in their particular facility, the top bunk was used for the guys that help out, that help the guy on the lower bunk. So there's various and sundry ways to do it. You certainly have to have, for many of them, ways of being able to get in and out of the cell with their walker or with a wheelchair to be able to turn around, things like that. Having grab bars by the toilets, having sinks lowered sometimes. So the kinds of things that we have an architect sitting over here who deals with ADA accessibility and so forth, and so dealing with a lot of those issues in a prison setting that haven't been dealt with before. And then also locating these units to where they're closer to the infirmaries, they're closer to dining, they're closer to the kinds of places that they need to get to or that need to get to those inmates. Another model that we did not talk about in the other session, but I happen to be based in Kansas with the University of Kansas Medical Center, and we've worked with the Department of Corrections there also. And what they have opted to do is take a facility that was a juvenile facility and was empty, was no longer operational, and turn that into the facility for the elderly inmates from all over the state. So they basically have just transferred all of the older, more infirmed inmates in the state to this one particular facility. There's advantages and disadvantages. You have a staff that you can train and you can bring them all up to speed and so forth. The problem is this facility happens to be in a relatively rural community and Kansas is a big state when you start driving it, and it's on the eastern side of the state. So if you happen to have family on the western side of the state, they could have an 8-hour drive to get there, so they're no longer in the institutions that are closer to their home bases, where usually there's some attempt to keep them. So there are some downsides to it too. It's also not very close to any kind of major healthcare facilities. So what we found with education of staff is just making staff, and this isn't just healthcare staff, because one of the things when we're working in corrections, it's a little bit different than when we're working in the community. We usually highly encourage that security be part of the education, that they come, so that the officers come to it, so that their superiors come to it, that classification comes, so that everybody's hearing the same thing, because we know it takes cooperation and collaboration from those groups also to get these programs up and going and to get the kind of care that we want provided in these programs. So helping people understand that certainly the elderly have a greater vulnerability to abuse and predation in the general population. That's usually one we don't have too hard a time convincing people of. That the elderly have less ability to tolerate and manage extremes, and that means extreme temperatures, environmental hazards, internal insults, whether it's illness, whether it's drugs, whether it's certain foods. That elderly just don't have that ability, particularly those with multiple chronic illnesses, don't have that that ability to keep that sort of homeodynamic state that the rest of us keep. We keep our temperatures within a certain range. We're able to keep our blood pressures usually within a certain range, and often they lose some of those capabilities, and any kind of insult can be pretty devastating and devastating pretty quickly. that they have a need for special physical accommodations in what is really typically a relatively inflexible physical environment. So prisons aren't known for being flexible in many cases. And the fact that they get to a point they can't climb stairs. And I've been into a lot of prisons where you have to climb stairs. There's no elevator there. Or you have to walk for literally blocks, depending upon how large some of these prisons are, and some are huge. So to get anywhere, you walk for a great distance. And I appreciated it a whole lot when I had some really bad arthritis in one knee, and was really to the point that I was having a lot of difficulty walking long distances, and I'd come to some of these prisons and we're walking, and I'm thinking, oh, I can't not do this. I now have a knee replacement. I can walk anywhere now, so everything's fine now. So there's a need for special physical accommodations, and so they need that flexibility. They have a need often for special programs and special privileges in facilities where it's not been recognized that inmates should have special privileges or special things going on. That, you know, that just was not something that was even a mindset for many facilities. For many prisons, it's like, well, no, we can't give anybody special privileges for any reason whatsoever. I think that's changing. I think we're seeing a definite change in that. And then the management of multiple comorbidities, the ways that we have to think about that. We recognized fairly early on that certainly for the healthcare professionals, that there was a need for education, and this is really no different than we're finding the need for education of our healthcare professionals out in the community. Most of our healthcare professionals who got out of school more than 10 years ago or so didn't have much geriatrics, if any. They didn't have any focus on care of older people, and weren't sensitive to some of the issues around medications, around the particular things that they needed to pay attention to with an older person. And so we've done quite a bit with our education around our healthcare provider group and looking at what are some of these differences in the elderly that we need to be paying attention to. A study that was done in 2010 found that inappropriate medications were prescribed to a third of older prisoners, and that about half of that inappropriate medication use was attributable to over-the-counter antihistamines. Anybody want to guess what antihistamine? Benadryl. What was it being used for? Sleep. Exactly, exactly. And so we find all these older inmates, and that's right up there at the top of the Beers list of don't do's. Don't give older people these drugs because they're going to get more confused, they're going to have likelihood of falls. You know, there's lots of issues around the use of antihistamines in the older population, and we found everybody was using them for sleep. The other thing is the underuse of gastrointestinal prophylaxis for those that are on the nonsteroidal anti-inflammatory. So things what's pretty common practice now in the community of using Nexium, using some of the proton pump inhibitors, things like that for people to protect the stomachs when they're on the nonsteroidal.
Nexium's not on the BOP formulary and they won't override it.
I know, it's there's a lot of work to get done in terms of helping people understand and Nexium is expensive. That's one of the.
It is, but it might be the only drug that.
But it's a lot better than having an intestinal bleed.
Yeah.
Yes, and what that's going to cost. Yeah. So, so we know that there's a lot of room for education, and it's not just in correctional providers. It's pretty much across the board that we're still asking people. How many in this room are familiar with the Beers list? Anybody? Got one back there? Okay. The Beers list is something that was developed many years ago, actually, as a list of drugs that are totally contraindicated in older people and those that should be used with caution, and only under what conditions you would use certain drugs in older people. And it's been updated over the years, and there's been a fairly recent copy of it come out. I ask people that work in long-term care this all the time and rarely have a hand go up. people are just not aware that there's a literature out there that really can guide them in terms of prescribing practices for older adults.
What is the name of that list?
BEERS, it's BEERS. You can Google it and find it. Very good list, very handy to have. And it tells you, you know, if you're going to use certain drugs, what precautions need to be put in place. So some of the examples of the curriculum, and this varies across who we're teaching, what people are wanting, but talking some about what an aging population means for healthcare and for security, how this changes somewhat the dynamics sometimes in a prison. Talk quite a bit about dementia, how to recognize when someone has dementia, because we're forever seeing, particularly with security, them taking guys down who, well, I told them to do this and I told them to do that. Well, they didn't remember 2 seconds after they told them, or they didn't even understand what they were saying, and that wasn't being recognized. We were at a prison actually doing education, and we're on break, and one of the nurses came back and was just beside herself, and they had gotten a guy who came out of his cell, who wouldn't go back in his cell. They'd call the dogs in. This was in Mississippi where they used dogs. And they had turned the dogs on him and taken him down and so forth. And she said, you know, all you would have had to do is go up to him. You know, I could have gone up to him. I could have taken a hold of his hand. I could talk to him quietly, and I could have taken him back in his cell. That's all it takes. But there's just not that understanding of what level people are dealing at and what's going on with them. Talk a lot with them about understanding and managing behaviors in persons with dementia. Talk a lot about what triggers behaviors in people with dementia, because we see this all the time in nursing homes too. We have people who will, be wandering, who will be screaming, who will be biting, kicking, you name it, that have dementia. And usually we can figure out what's going on. Sometimes they're in pain and you're trying to dress them and you're pulling on an arm that they're having pain in, and they're going to hit you because they can't tell you what's going on with them. Sometimes they're wondering because they need to go to the bathroom and they can't find the bathroom. They can't tell you what they need. Often it's pain. We find pain's right up there at the top of the list, and sometimes it's just trying around a pain medication, trying something with them and seeing if it doesn't calm them down. But a lot of it also is just recognizing also what goes on in the environment, because the more chaotic the environment is, the more likely you're to have people with dementia acting out. They really can't take the stimulus, and so they start responding to it, sometimes with some aggression or agitation at least. Identifying causes and reducing risks of falls is a big one. Just trying to teach people how to modify the environment to lessen the likelihood that people are going to be tripping over things, but also activities that they could be doing that would help improve gait, improve balance, provide strength, lower extremity strength. Simple kinds of things they could do that we know helps reduce falls. Identifying and managing pain in older adults. I know there was just a session yesterday about pharmacological pain management. I know there's lots of issues around pain management in the prison population because of the history of a lot of your inmates and substance abuse and so forth. But in many cases, your older inmates are going to have pain, and about all you have to do is look at what diagnoses they have. And you can pretty well guess that they're going to be living with chronic pain with some of those diagnoses. And then just medications generally, as I just talked about. We also do a little more of the touchy-feely, so to speak. Security always loves this. When we talk about crime and caring, that you really can have a caring environment at the same time that you can have security. And since we work across a number of prisons, we can give examples. And it never starts out, you always start out with people thinking this cannot be done. You cannot show compassion. You can't really care. We can't have you touching people. We can't have all this. We can't have families come in when someone's dying. You just can't do that because we can't maintain security. And we usually say, well, maybe that's so right now. But let me tell you about this place and what they've been able to do. And it's not a place that's really that different, maybe even a tougher prison. Yeah.
One of the things that we've started doing at Tennessee Department of Corrections, we're actually training those officers. We actually had a whole session where we strictly to train the officers on the therapeutic community or on the age population, just to train them on why we were doing, or what services we were performing and why we were doing it. And it wasn't, as some say, hug a thug or the
Yeah.
caring. It was actually for treatment services.
Right.
It was actually to better the offender. A lot of the officers, when they walked in, we did a poll when they first walked in, and then we did a poll when they left, or as they were leaving. The poll when they first came in was, why are we here?
Yeah, this isn't for us.
And the first sign of touch that needs to be taken down. When after the training, they thought, this does make sense. We understand now. We won't react the first time we see you respond to the offender in a, hug a thug way. But that we understand that it is actually a treatment service versus an actual inappropriate action.
Yeah, and that's important. She was saying, and they're recording this, so I'm going to have to repeat some of what you said. Yeah, but she was saying that in Tennessee, they're actually doing this as part of training for correctional officers when they come in, and that they're doing it as part of, this is part of being a therapeutic environment, and as a part of the programming for the prison. And she was saying that they provide them with sort of pre-attitude before they take the course and then afterward. And they're saying initially that well, if we see one incident of touch, you get taken down. And then when they're leaving after having the course, well, maybe we really wouldn't do that after one. And that's an interesting thing, because we found we were teaching in one prison that really had not had any of this kind of training going on, and it was around doing palliative care and hospice care in the prison. And we were talking about the importance of touch sometimes, and appropriate types of touch. And we had security, we had the healthcare staff, we had mental health, we had them all in the room together. And several people from the healthcare staff or mental health said, well, if we do that, if we touch them, we're going to get written up by security. And security was kind of like, no, we wouldn't. We know the difference in what's, a compassionate kind of, and something that, is going beyond that. We weren't going to write you up for that. And so nobody ever talked to each other about it even. There hadn't been those discussions because they thought that was just sort of off base. You just, that of course they were going to get taken down for it. So, that's one of the areas we spend a fair amount of time on, with pointing out ways that it can be done. But it's not going to happen overnight. It's going to be one of these things that it has to evolve slowly in most institutions. They have to become comfortable with each other. We want to get health care and mental health and security working very closely together, viewing themselves as working as a team, particularly in these kinds of units. And there's some handpicking of the people that work in these units often. Most of the facilities get very good about saying, well, we wouldn't put that officer in that unit, but this one would be good. And sometimes they find out, down the line that it's even one that they thought wouldn't, once they catch on to it, really become one of their best workers. Yeah.
It would be nice if we could have advanced an idea to NCCHC of one of the credentialing checkoffs. For example, it's not a far reach to make that happen as formal education requirement, because in the MAT programs where we're doing methadone, I'm required to instruct each time custody does a rotation, the next CO on the signs of detox. And it's an acute detox unit, you've got to know what you're seeing to be able to pass it on to us. And why not that?
Right, yeah, and he was saying that to have this as a part of credentialing that NCCHC could be doing for correctional officers, that they get this training and that they certify and know what the appropriate role would be for what they would be doing in these kinds of units. So I think that's great. Another area is the communicating with the older adults. We find that often there's not much understanding of some of the sensory impairments that older adults have, that they can't see as well, that those gray stairs, they're not going to be able to differentiate. They're going to fall down the stairs very easily. You've got to pay attention to that. Shadows, if there's anything laying in shadows, they may not see it when they're walking. They can trip over it. Keep an eye out for that. That they can't hear, and particularly in the day rooms and so forth in a prison, it's so noisy, and you're bouncing off concrete walls, and the noise is, and it's very difficult for anyone with a hearing impairment, old or young, to be able to understand what's being said. So often they're not able to, even if they're given an order of some kind, they can't understand it or they can't hear it. So understanding what it takes and how you better communicate with the older person in terms of making certain that they can understand and hear what you're saying, that the environment is adapted in a way that they can function best without chance of injury, things like that. Ethical issues in care of older adults, we sometimes deal with this, and there's lots of issues around to release, not to release, to, advance directives. We've been in places where they say, well, we can't do advance directives, it's not allowed by our state. And then they go back and check and find out the state didn't prohibit them from doing advance directives with inmates. They could do an advance directive. So, there's lots of things just to bring to people's attention that these are options out there. We also work with the staff around working with offender helpers. This might be something that even staff needs a little training on, being able to understand what the role might be of offender helpers, and also having input into that role. So, like I said, in every place we go into and do training, it's a little bit different in terms of what's allowed, what's not allowed. I found real quickly I had to learn a whole new language and learn a whole new set of behaviors of what you can and can't do in prisons, and it's different in every one. Some you can wear open-toed shoes, some you can't. Some you can take lipstick into, some you can't. You never can take a cell phone in. I've learned that. Cell phones are the one thing I've learned you will not get in the door with. But everything else, it's pretty amazing. Seems to be negotiable or something. It's one of those things that every place is a little bit different in what they're going to be comfortable with initially. Developing an effective care team. We spend a lot of time really talking about working as teams because and we're talking about this a lot in the community, that when you're working with older adults, when you're working with people with multiple problems, social problems as well as possibly mental health problems as well as physical problems, you need a team there. No one person is going to be able to do this by themselves. So security working with the healthcare, the nurses working more closely with the physicians, with pharmacy, with any allied health people that might be there, certainly working with any of the dietary people in your facility. You're the ones that can educate them around diets. I know a lot of that's controlled by what you can buy and so forth. But it's pretty amazing sometimes when you go in and look at the menus, so to speak, in the prisons and what people are getting and know what kind of health problems are in that prison. And of course, even if they try to feed them healthy, then they go to the vending machines. Well, we've managed to have some control over what goes in vending machines in schools and in the community. So, it wouldn't go over well, I'm sure, in the prison if they got their ho-hos or whatever taken out of the vending machine. But sometimes, we've taken tobacco out of a lot of our prisons, so it can be done. To give them more healthy options for what could be in those machines for them to use. And that's part of healthcare. That's part of teaching. It's part of the role of healthcare. And another area that I'm going to have Jennifer talk about, because she does a really good job with this and working with our daily living attendants and with staff, is around grief and bereavement. Because I think something we often don't think about is that often if you've worked as a healthcare professional or in these prisons for years and years and years, you've gotten to know these prisoners very well. You've gotten to know these inmates. Some of them, you really kind of like. They're almost like family. You expect to see them every day and so forth. And when they become incapacitated, when they die, there's going to be some grief and some bereavement. even on the part of staff. I mean, sometimes we don't like to think about that, but it happens. And staff can burn out. Certainly we see the DLAs can burn out. We want to prevent a lot of that, and we want people really dealing with their grief and bereavement so that it doesn't come out in unhealthy ways. So, Jennifer, you want to talk a little about what you do?
My name is Jennifer Turnage, and I'm the Chief of Mental Health at Jefferson City Correctional Center in Missouri. And we kind of offer programming on a couple different levels. Number one, we offer programming for our daily living assistants and our hospice workers. We have a grief and loss group, and what I began noticing is in working with our enhanced care unit, and after our first offender died, the effect that it had not only on the other offenders living in the unit, but the DLAs and also myself and the staff. And so what I implemented was this grief and loss group. And I cycled every DLA and every hospice worker through this group. I kept them in smaller numbers. And it was an 8-week group. And we just talked about the issues of grief and loss. It wasn't just as it pertained necessarily to their work. That was obviously a focus of it. But it was also about their own grief and loss, loss of freedom, their own losses that they've had in their lives, and how they bring that to the table when they're working with these offenders, and how that affects their care of the offenders, how they need to keep their own emotional and cognitive well-being in a place that is healthy so that they can help other people. So it was just a place, it was a group where we could sit down, we could share, we could talk about what was going on currently in their work. If they had a particular offender who was ill, who got moved to the infirmary, who was on the point of dying, we would talk about that offender. We would just be there for each other, and we went through that process, and I cycled all of the healthcare workers, the inmate workers, through that group. We also offered a group for the offenders who are enrolled in the enhanced care unit, and that group was a little bit different. It was more of a cognitive, emotional type group. We did lots of different activities. We did things to help fine motor skills, such as origami. So we would, simple origami, I'd sit down, we'd show them how to do it, teach them, the working on the fine motor skills of the folding and the creasing and all of that kind of thing. We did name that tune. So we had music and play a bit of a song and see if they could name the artist or name the song. And one of the things that I brought to the table that I learned from being an educator is that nobody is ever too old to enjoy being read to. And so we would get a book and we would read a chapter but at the beginning of each group. So for example, I read Where the Red Fern Grows. Okay, and we would read one chapter each week, and we would maybe talk about it. They would just sit and enjoy, and a lot of them had never read the book, and we would go through that process together. And we cried at the end together. All of us did. It was it was an interesting story or event that occurred in that group, but. So we did things like games, we would music, the origami, the can you follow the directions and do this particular thing? So we worked on the thinking aspect of it. We would even just sit down sometimes and say, what's on your mind? You want to gripe and complain about maybe what's going on in the enhanced care unit? You got a particular something you think needs to be changed? Okay, well, we can sit and we can talk about that too. Or we can talk about what's going on in the news, and we can process about how that's affecting you and your thoughts about that. So we worked on the cognitive and the physical piece with the offenders. We also have a music group that goes on. We have an activity technician who brings over a couple of guitars, and he has a piano that he pulls out every once in a while, and we'll just go into the actual unit, sit down at the table. There's another offender who knows how to play the guitar well, and there's stacks of music, and the guys can come over and say, I want to sing this song, I want to sing that song, let's do this one, and they'll just spend an hour playing music and singing. And everyone benefits from that because they're either singing, which they enjoy, or those that don't really want to participate, but they're out listening. And so, you know, we have all different kinds of music, anything that they could want. And so we engage them cognitively and emotionally through those types of activities. The daily living assistants are welcome to join in on that as well, which they do. And so those are some of the programming that mental health has implemented, not only with the offenders enrolled, but also with the daily living assistants to help deal just with all of the problems that occur in that kind of an environment and with that kind of work. You know, there were times where we sat and cried together because an offender had died suddenly the night before. And, you know, so mental health went over there, and we were able to just kind of, with the DLAs, just to sit in a circle and talk about, you know, memories, and put a picture of the offender up on the wall, and so that they could remember him for months after that. You know, we just did things like that to help them deal with the emotional toll that being a healthcare worker can oftentimes provide for the workers.
Thank you. So that covers some of the things that we're doing, some of the examples of the curriculum that we're using, particularly for the daily living attendants, inmate helpers, whatever they happen to be called. Is talk about why older people are different, and it goes back to the same thing we talk with the healthcare professionals about, why you have to really pay attention to what's going on with that older offender when they're out in the yard on a 100-degree day in the sun. You know, that they are going to potentially have hyperthermia much more quickly than a younger person would. They're going to dehydrate quicker. You got to pay attention. You got to make sure they're drinking fluids. You got to get them in the shade. Some of those kinds of things that they, I think, often don't think about. You got to get them dressed appropriately if they're going to be going out in sub-zero temperature to go across the yard for something, or maybe not even take them out, like some of the places now don't have them, you know, actually go out for meals and so forth when they're when it's too cold outside, and they have to be transported outdoors. And sometimes there's quite some distance to get to outdoors, to get to other buildings. Talk to them a lot about what dementia is, how to work with people who have dementia, and they become really, I've been impressed with watching the DLAs and watching other inmates that work in these kinds of roles across prisons, in that they become very good in working with these guys. They become very good in anticipating when they're starting to get agitated and figuring out ways to get them calmed down, to get them diverted to something else, get them doing something else, and calm things down, and sometimes just reassure them. Just say, yeah, hey, I'm here with you. Everything's okay. You know, let's go over and work on this puzzle, or let's go for a little walk, or whatever it takes to calm things down. They can be very effective. Being aware of the risk of falls. They can do a tremendous amount to make sure that these guys that they're working with and taking care of are maintained more safely within the unit. Communication, again, we work with them a lot on how to communicate, how to get face-to-face, get down on the level of the person you're talking to, get face-to-face with them, make sure they can see your lips, talk, you know, don't scream at them, just talk in a lower toned voice so that they have a chance of hearing you, helping them understand vision changes. And I didn't bring it, regrettably, I've got a great picture of a painting that Monet did when he was young, famous painter, and it's of a Japanese bridge. And he did that exact same painting when he was in quite advanced age and had a lot of yellowing of the lens of his eyes that often occurs with aging, and some cataracts. And it's the same scene, but looks totally different. It goes from having blues and greens to having oranges and browns and yellows. You have to really look at it to realize you're looking at the same scene. But it gives them a real visual of how much vision can change, and how that yellowing of the lens, how cataracts. We also occasionally use some sensory kits where we have glasses. We use this with students too all the time, where they put on the glasses and it gives them the sense that they have tunnel vision that you get with glaucoma, or they have macular degeneration and they can only see around the periphery, and we have them do activities and realize what it's like for somebody that has those kinds, or we have glasses that mimic cataracts and the blurring of the vision, and you get an idea of what it would be like having to function like that, put gloves on their hands and have to pick up pills, and some of the sensory deficits that people have. So it's an eye-opener to people about what what people are facing sometimes. We also talk to them about working with healthcare providers. You know, how to communicate with healthcare providers to be listened to. And we do the same thing with aides in our nursing homes in terms of how you observe and how you document what you're seeing and communicate it to a healthcare provider in a way that they're likely to listen to you. So you just don't go in and say, you got to do something because he's in pain. You know, you better go in and you better say, you know, I noticed Mr. Smith today is not moving around very much. He's not getting up. He is guarding when I try to move his arm. Do you think you could go take a look at him? You know, better ways to communicate, and also better ways to observe and document that really help that healthcare professional have some idea, that provider know a little more about what's going on and whether there's a real sense of urgency in this. We also talk to them a lot about the changes with aging, and they're the guys that often are going to be the ones that are helping these guys get dressed. They may not be doing a lot of the hands-on, but they help them get their socks on sometimes. So having them really pay attention, you know, we've got a lot of diabetics in the prison, lots of them. So making sure that they're paying attention if they happen to see an area of redness or a little blister on the side of the foot or the toe or the bottom of the foot, to recognize that that's a real problem in somebody that's diabetic. You know, looking at, you know, what lesions they might have, because nobody else may see those, and that inmate may not be able to differentiate. And often when they go in for sick call or something, they're not stripped and looked from head to toe. And so showing them what different lesions can look like and what needs to be reported, and or somebody's developing what maybe is a decubitus from laying in one side, to make sure that they recognize that what's going on and help them understand, you know, helping turn people, helping them move around. We don't have as much problem like on the unit where Jennifer is right now, because we don't have that many that are totally incapacitated, but we do with wheelchair, particularly if they're paraplegics and so forth, because they're not feeling. So somebody's got to be paying attention to whether they might be just sitting there too long and developing decubes and so forth. So sort of paying attention to that. At one time I decided I maybe had gone a little too far, because I was actually showing them some pictures of lesions, and I happened to mention something about melanomas. And you know, if you see something that, you know, is a strange looking, looks like an EVI but it's really not, and meets these characteristics, and I had them all lined up after my talk. See that lesion right there? Do you think that might be a melanoma? So I said, okay, well, maybe we need to not be quite as graphic about this. But, you know, just to make them aware that they may be seeing things, and they may be seeing symptoms of things. They may be seeing, you know, talking to them about if somebody is confused and they haven't been confused, or if they've been confused and they're much more confused today, to make sure and report that, because that's often a symptom of illness in older persons. That's often the first symptom we see of illness in older persons, is that they become more confused, or they become confused for the first time. They're just not as oriented to what's going on, and usually we can bet it's a urinary tract infection, it's an upper respiratory infection, something's going on. And it needs to be, you know, it needs to be evaluated right away, and, you know, appropriate treatment given, because older people are the ones we see the most often in the emergency room with sepsis, because things have gone on too long and they weren't recognized. So helping them just recognize the red flags. They know these guys, they're like the aides in the nursing home. They know these guys better than anybody else, but we also make sure that the officers are hearing this, because they also know these guys. And often they're the ones that notice when there's something really different going on with somebody, and they're the ones that can report to health care and make sure that they get in to get seen. We talk with them about the helper's journey. We talk with them about what an important role they're playing. Many of the guys that we work with and that train, will tell you, I've done some really, really bad things in my life. I did some horrible things. But it was a long time ago, and this is my way to finally pay back for what I've done. And they see this as a calling, as a mission. To them, it's to some degree redemption for what they've done, and they're very dedicated to those roles and to what they're doing in many, many cases. And we said, that's good. That's what it should be. And, it's okay. They also, it's an opportunity, it's very interesting when we're teaching the classes. You see these guys and women, when we've done the women's prisons, open up about things that they've never talked about before, because it's a safe environment and people can be more vulnerable. And in the prison, they can't be vulnerable. Out there in general population, they couldn't talk about the kind of things they can talk about within this group. And it's pretty amazing to see the stories and to see, here are these really tough guys who will cry over something they've done or something that's happened to them. And that's why I think, too, the grief and bereavement, because I think a lot of this comes back, when they're seeing guys dying and they're realizing that, we're all headed down that road at some point. And a lot comes back on them, and a lot of them have seen a lot of death and seen a lot, or they've lost people. They've lost, their mothers while they were in prison and they couldn't go to the funeral. They can't resolve. They don't have the opportunity to go to funerals often and resolve, that are used as rituals that we use to resolve grief or to help people get through things. So they can't often participate in those kinds of rituals we do as a society. Active listening, teaching them the importance of just listening, that they don't have to talk. And we'll put them through exercises where they have to sit and listen to somebody else, to one of their cohorts, talk for 5 minutes. And this is often when these stories come out. And they talk about very personal things. In fact, it very much amazed us the first time we tried this. We figured they'll talk about the weather, they'll talk about something, but it wasn't important what they talked about. It was just they had to sit there and listen to their partner talk about something for 5 minutes and not open their mouth. Just listen. And really listen. And they were talking about the most personal things. It really was surprising to us, but it seems to be the first time they were given permission to actually talk about something that was very personal, have somebody really listen to them, to what they were saying. And so to teach them how to do that, and we particularly work with that around hospice volunteers, to teach them how to listen, that they don't always have to respond. They just have to listen, and they have to be looking at them, and they have to show appropriate behaviors that they are listening and actively listening to them. And then we teach them about self-care, that they got to take care of themselves. And this is one of the areas where I said we've had some ups and downs with some of the programs, because we do have a fair amount of burnout sometimes, that it just gets to be too much. So we've got to figure out ways to give breaks. We've got to figure out ways for them to better take care of themselves, to help them also not feel that they're on call 24/7, taking care of somebody else, because we all know that we burn out caregivers and families that way. We burn out lots of people that way. We can't expect that of somebody, that we have to give people breaks and give them ways that they can help take care of themselves. And, there's lots of ways. We even, deep breathing, lots of things to just help them kind of, not desensitize, but to decrease some of the anxiety that they get to feeling, or the tension that they're feeling at times, but also to support each other, and that they're working as a team together. They're not there by themselves. There's lots of other people there working, and to use those people as part of your team and your support group. We've already talked about grief and bereavement. Safe and effective activities to do with older adults. We really like the DLAs, and Jennifer's worked with them a lot around those kinds of things, that often they can carry on after Jennifer leaves, or after some activity person leaves, or music, that they can carry on. And we tell them, work with these guys, figure out activities, and then come up with some pretty fun stuff for them to do, or things that or stimulating and get them out of their cells and get them out into the day room. There is some equipment available. This is a stationary bike that has a swivel seat so that even if they're in a wheelchair, they can sometimes transfer it to it more easily. Or I would like this because I think that stationary bikes are sometimes a real pain to get into, depending upon how they're set up. There's games and so forth. My favorite are pets. How many of you are in a facility where you have like a puppies for parole program, or you do training of dogs? Yeah. Those are phenomenal programs, both for the inmates that have those dogs, have that responsibility, or doing that training, but to be able for them to bring those animals over to these units and work with guys with dementia, or the guys that are, just sometimes they just don't relate to people, but they can really relate to those pets, to those animals. Now, I don't think the yappy, barking, jumping dog is a good idea, but the calmer ones, the ones that, I have a black lab mixture that was a rescue that I think would be great for this, because she'll come over to you, she'll put her head in your lap, and she'll just sort of press down until you notice her and pet her. Very gentle about things, but we've seen the very positive effects of pet therapy, whether it's in hospitals, nursing homes, or in prisons. It's amazing. And as Jennifer said, music is phenomenal. Live music particularly, where people can sing along, where they can listen, has a tremendous effect on people's ability to sort of perk them up or help them calm down. We can do both. Sometimes people have been asked about whether you're doing certified nurse aid training. As you can tell from this curriculum, we're not doing certified nurse aid training. It is being done some places. We could do it. Most of the facilities we worked with aren't to the point that they want to give that much hands-on responsibility, so we haven't done it. I think they're actually great programs. We've talked about working with our voc techs, and actually we have a voc tech in Missouri that's doing that with one of the women's prisons. Doing a nurse aid course. One of the issues we deal with is we get them trained, we get them certified as a nurse aid, and they can't get jobs when they get out with it. So we're trying to figure out ways to start breaking into that and working on that. We do have our facility in the women's facility that has the nurse aid program. They're actually taking them out to a community nursing facility for their clinical. So there's hope. We're slowly making progress. And it's not just the facilities that are the problems, it's their insurers. So I think we're going to have to also deal with the insurers and try to figure out, some that are willing to take some risk and who are willing to attempt some new things, because we certainly need well-trained people out there as nurse aides. In our nursing homes and our hospitals, we need them in a lot of places, and often this is a group that are very, very good at what they do. And they've had good training and they've had good experience behind them, so, and they need jobs when they get out. So, okay, any questions? I think I'm getting the time button back there. Yeah? Mm-hmm.
One is the confidentiality issues with the patient's medical history. And number two, do they interact with the offender's family?
Do they
interact with the offender's family? The one they're taking care of, do they ever interact with their family?
Not typically.
No.
Not typically.
No, he was asking if, number one, the offenders, the ones that are taking the DLAs, if they're interacting with offenders' families, and also what was the confidentiality issues. Confidentiality, they are not privy to the medical. Now, they often know it. I mean, often the guys are taken care of tell them what's going on with them, but that does not come from medical. And there are actually some places that particularly in some hospice units, that some of the hospice volunteers do interact with families. So it's not unheard of. Yeah, it is done. It's not done, not in the program at Missouri yet.
So even if they have like a family visit, they wouldn't go with them?
No, not necessarily. No. Any other questions? Okay, thank you all. Thank you.